various gliomas that I mentioned to you. So if you look at the incidence of all primary brain tumors, this gives you a rough idea of incidence. So in this pie chart, they've included all primary tumors. So meningiomas, pituitary adenomas, nerve sheath tumors are included. And you can see that those tumors actually are much more frequent than the gliomas that make up the smaller part of the pie chart for all primary brain tumors. If you zoom in and just focus on the incidence of all primary malignant tumors, then this is where you can really see how glioblastoma stands out. So for all of the malignant tumors, this is the one that makes up 50% of the pie. So that's why our focus is always there when we're trying to figure out how to better treat these tumors. All right, so that's a lot about classification of these tumors. So what about diagnosis? So of course that starts with imaging. Most folks in the field would say that they could do a pretty good job at identifying a glioma on an MRI image. Of course, the challenge is figuring out the type of glioma and the grade of that glioma. So that requires the histology work. And of course, as I just illustrated, genomics is now required to further define these gliomas. So to kind of illustrate that, what I'm going to do is I'm going to go through some of the typical glioma examples in each grade category that you're going to come across. So here's a prototypical WHO grade 1 type glioma. That's the Pilocytic astrocytoma. So it's much more common in children, occurs primarily in those first 2 decades. It can arise anywhere in the CNS, but here are some of the preferred sites like the optic nerve, thalamus, hemispheres, cerebellum, brainstem, spinal cord. In my adult population, by and far the most common place I see this tumor is in the cerebellum. In fact, I had a patient 2 weeks ago who had a recurrent polycytic astrocytoma in his cerebellum. On imaging, these tumors are usually very well circumscribed and contrast enhancing. So here is an axial T1 with contrast MRI picture showing a cerebellar tumor, very classic picture of this type of tumor where you have this enhancing nodule associated with a large cyst. And this specimen is a great example of how it's a very well circumscribed, well defined nodule with that cyst. Histopathologically, what do they look like? So this astrocytic tumor is relatively low cellularity. It has a unique biphasic pattern. So there's a compacted area of bipolar cells and Rosenthal fibers, and then there's another pattern of loosely textured areas with multipolar cells, cyst, and eosinophilic granular bodies. Very rare to see things like mitoses, atypia, microvascular proliferation. The Rosenthal fibers, these are these corkscrew-shaped eosinophilic fibers in the astrocytic processes made up of alpha-B crystalline. Those eosinophilic granular bodies, these are aggregates in the astrocytic processes made up of alpha-1 anti-chymotrypsin and alpha-1 antitrypsin. So here's a little bit of what that looks like. So if you step back, you can kind of see the biphasic pattern. There's the compact areas and the loose areas. Here's an example of those Rosenthal fibers, those long squiggly eosinophilic fibers inside the astrocytic processes. As far as markers on immunohistochemistry, so these are the heavily GFAP positive gliofibrillary protein, and the Ki67 index would be very, very low, 1%. So that refers to the number of cells that are cycling or mitotically active. As far as any sort of genetics, you have to think about NF1. So NF1 patients, 15% of them will develop these types of tumors, and especially in the optic nerve. Remember, NF1 gene is on chromosome 17. It's a tumor suppressor gene. In contrast to the other astrocytomas that we'll talk about, TP53 mutations are very, very rare in this tumor. It does have chromosome 7 and 8 gains. So the prognosis is excellent. Surgery can cure these patients without any other adjuvant therapy. All right, what about WHO grade 2? So sort of the classic one there is the well-differentiated astrocytoma. Historically, we used to call this low-grade glioma. That term has kind of fallen out of favor a little bit. So this is a little bit more frequent, 10 to 15% of the astrocytic tumors. It occurs in a little bit older population, average age of about 30, equally in men and women. As far as where it occurs, you see the most common location supratentorially in the frontal and temporal lobes. On neuroimaging, this is what a typical grade 2 glioma might look like. It's non-enhancing, and it's going to typically be very bright on T2 or FLAIR images. So here on the left is a T1 plus contrast axial MRI image. So very well demarcated lesion that's dark, not contrast enhancing. And here's that same picture, but the T2 sequence. And you can see how bright and FLAIR enhancing this is. I would say most glioma surgeons probably encourage folks to use this image when you're resecting these tumors in the operating room. Histopathologically, these are tumors that have well-differentiated cells. So well-differentiated fibrillary gematocytic astrocytes on top of a mild microcystic tumor background. A little bit more hypercellularity, occasional atypia, but really no mitotic activity, no microvascular proliferation or necrosis. And this is a sort of a typical picture of what that might look like. These cells will also be positive for GFAP as well as Vimentin and S100. So those are going to be strong markers for most of the glioma tumors. That is, most tumors that are well differentiated. So as you get more malignant, more undifferentiated, these markers are less obvious, less prevalent. Ki-67 index is going to be higher, so it's up to 2 to 3% in these grade 2 tumors. All right, here's a grade 3 tumor. So this is your typical anaplastic astrocytoma. These are in a little bit older folks, and now the average age is up in the 40s. They're located in similar places as the grade 2s. And on imaging, so now we're starting to see signs of enhancement. So sort of the classic description will be a ring enhancement pattern with a central area representing necrosis and surrounding edema. So you can see a good example of that here in this coronal view. Again, this is a T1 sequence with contrast. So ring enhancement with likely surrounding edema. Now remember, all these classic pictures I'm showing you, they're not diagnostic. They are classic, but not diagnostic. So always remind yourself to include a good differential diagnosis when you're looking at these MRI images. So as all of you guys know, this could look very similar to a secondary metastatic tumor. It could look similar to an abscess. So again, don't forget about differential diagnosis when you're looking at imaging. Histopathologically, so these tumors are going to be much more densely hypercellular. There's going to be much more obvious nuclear atypia, increased mitosis, prominent nucleoli, and might even see multinucleated tumor cells. This is a little bit of what they look like. So you can see a bit more hypercellular, but what's really now different is this remarkable cellular and nuclear atypia. You're also going to see more mitotic activity and more vascularity there. So again, these will be positive for GFAP Vimentin S10. Ki-67 index is going to be a little bit higher. So now we're kind of up in the 10% range. The genetics are now also going to start getting much more diverse and interesting. So these are a few of very well-established mutations seen in grade 3 tumors. These have been known now for many, many years. including TP53 mutations, P16, RB, P10 mutations, CDK4 amplification, chromosomal abnormalities in these. And now we're starting to see this EGFR amplification. Of course, there's many other growth factor pathways involved as well. And this is going to really take off in that grade 4 tumor. So now prognosis is different. Prognosis is much worse. It's now these tumors are going to be treated like a malignant tumor and require adjuvant therapies, and going to be treated the same as grade 4 GBMs. Okay, so lastly, here's an example of grade 4. So this is your glioblastoma. So like that pie chart I showed you, these are the most common astrocytic tumors. Peak incidence is going to be in an older population. The average age is about 64. These are a little bit more common in men. And again, they're more common supratemporally, especially in the frontal lobes. On imaging, these look similar to the grade 3 tumors, but there are signs to suggest more aggressive behavior. So it's going to be a little bit more irregular shaped lesions. You still have this peripheral ring-like enhancement. You'll have this central zone of necrosis. And over here on this T2 sequence, you can really see how much edema these malignant tumors can incite. To give you another example, I have a current patient who came in about 2 weeks ago, walked in with a headache, and he has a malignant glioma that's centered in his insular lobe, but it actually spreads out into most of his hemisphere. And he's got so much edema that he's got remarkable midline shift. And within days, he started herniating without any sort of intervention. And that led us to a quick hemicraniectomy. So these tumors can change quick, and you have to be very aggressive at taking care of these folks. I thought this specimen is a good illustration of how infiltrated these tumors are. So you can imagine that on the MRI, this central area of necrosis is probably where your focus is going to be on that MRI, but you can easily see how infiltrated these tumors are and how much those tumor cells spread beyond that focus, even to the contralateral hemisphere. All right, so to wrap it up, histopathologically, again, diffusely infiltrating, very hypercellular, poorly differentiated cells, lots of pleomorphic tumor cells, very high mitotic rate. Now you see a lot more microvascular proliferation and necrosis that's called pseudopalisading. The immunohistochemistry is a bit more variable, but you might see some GFAP positivity. Ki67 is much higher now, up in the sort of 20% range. And again, the prognosis is very poor despite all the therapies, with an overall survival of about 1.5 years. So this is what it looks like. So cells are much more dense, much more pleomorphic. Here's a good example of that classic pseudopalisading necrosis that I mentioned. These tumors characteristically are going to have hypervascularity. So here's a good example of that. And sometimes they'll have some unusual cell types. So here's just one example that's called a giant cell glioblastoma that has these big, unusual, odd giant cells and multinucleated type cells. The interesting thing here is that if you diagnose that, they do have a little bit better prognosis than the general population of glioblastoma. These aggressive tumors can have sort of sarcomatous transformation. It looks a little bit like that. And again, the GFAP is positive, but it's more variable, not quite as dense as in those other more differentiated gliomas.
Hey everyone, Ryan Rad here from neurosurgerytraining.org. If you like that video, subscribe and donate to keep our content available for medical students across the world.